private clinic. Me and Professor Former and Valentine, we were there last year, and we really enjoyed the high-tech and the nice clinic that you are managing. So we would like to welcome you also in our international podium, and please welcome Dgzi with me.
Thank you, Dr. Tamimi, Dr. Borma, Dr. Hill. Thank you to join Dgzi Congress here. It is an honor to be here and speak my presentation in Dgzi in Hamburg, in Germany. Today, the topic of my presentation is immediate implant placement in the anterior and the femoral upper tooth with using CT scanning. In examination of the maxillary front tooth, we often have trouble with dividing to near lateral tooth and gingiva. The advantage of immediate implant placement are time saving, less traumatic and costly, minimize the bone resorption to occur after tooth extraction, effectively aesthetically store the form of the soft tissue as much as possible. Number of operation times can be reduced and shorten the healing period, and easy prosthetic operation afterward. We have some trouble of stage approach because changing of the soft and hard tissue morphology and occurrence of the difference of gum line and anterior tooth due to vertical incision and incision in the interdental papilla. There is a comparison of the stage implant placement and immediate implant placement. The number of operation, stage approach, twice, immediate approach, once. Time of healing, stage approach, long. Immediate approach, short. Absorption of the bone, stage, much. Immediate, less. GBR, large. Immediate, small. Saving soft tissue. Sometimes no. Immediate approach is almost yes. The other advantage of extraction and immediate implant placement are preserve the rich width, keep interdental papilla, less disruption of the blood supply, prevent the disruption of the soft tissue architecture, decrease the total treatment time, in spite of having those many advantages. Why we don't use the immediate implant placement all the time? That's because it requires some experience and needs working knowledge and high skill. It is not clear outline, form, or shape of the alveolar bone. It is not clear shape of the extracted socket for implant placement with normal X-rays. So, using the CBCT for immediate implant placement is more reliable and comfort for implant operator to know the sequence of the implant operation, and the patient can receive the detail with explanation with image. This CBCT in my clinic, right picture is the treatment room. So that quickly I can explain the patient that see this image. So it's easy to understand for patient to my operation sequence and in detail. There is a concept of the bone, triangle bone with CT image. Dr. Hayashi showed the triangle bone schema in the article in Journal of Clinical Prosthetics 2008. The concept of the triangle bone is created by three lines. One is the labial side tubular line. Second is palatal side line. And third is the base bone line. This is created by a triangle. He said the implant should be pressed into triangle bone, which is native bone. And he also said the implant should be pressed to palatal side with parallel to labial side line to obtain more space to prevent the labial bone desorption. Like this, like this. The other concept of HDD, HDW, horizontal defect S. HDD is horizontal defect depth. Distance HDW equal HDD, or HDW less HDD. In this case, not necessary to use bone graft and membranes. Dr. Buza also described the article. The defect more 2 mm. It needs bone graft due to prevention of the horizontal bone desorption. This is my case of the stage approach. I had a difficulty and problem. Female patient, 50 years old, and the tooth number 9. Patient come to my clinic due to root fracture. I accepted the tooth and wait for 4 months. Then I placed the implant. After 4 months after, I cut incision. To avoid the interdental papilla, I did a wrong incision line. So outcome of the margin of the temporal crown is deceived. Of course, patient is not agreeable. So I did the gingival transplant. I put some gingiva to labial side. Then this is 6 months after. So it is concept. It's okay, but the patient is not really agreeable. So therefore, immediate implant is more gingival stable, and the clinical case of extraction and immediate implant. This patient came to my clinic within having the toothache, tooth number 8. When he was young, he had a traffic accident. When he bites some very hard food, so his tooth is moving. So I extracted this tooth, and immediately I pressed the implant. So I make the preparation for canal or implant. So I press the implant. Then that time I set the abutment and set the temporary crown. This is the final restoration after 6 months and the CT. Other case of the extraction and the implant patient is 43 years old. Tooth number 9, also she came to my clinic to having the pain in the tooth upper left central. So I extracted this tooth and I made the canal for implant. There's a space between implant and the margin of the socket, more than 2 mm. So I did the gingival graft. After I finished the grafting, I used the collagen membranes called the teldermis with mesh. I used to do that, but now I do a immediate rod implant. But before I used to do this, it looks too big, but a couple of days after, it shrinked. So patient, or when patient smile, it doesn't show like this one. This is 6 months, and I placed the temporary crown. This is after 3 years old, the final set. and CT. The labial side, we have it has lots of bone. So I'm going to show you the movie, this sequence. I extracted this tooth. I prepared the canal for implant. I changed the bar, bigger size. By doing the expand the bone or using the osteotome, then I press the implant tightly. In this case, I usually use it by hand to know more tight. I remove the cap and set the cover screen. So there is a space, so I use the bone graft. So I show you the quickly movie. Usually it's slow, but there's no time, so. So I'm using the plug-in membranes with mesh. It looks bigger, but it shrinks. So I'm making the temporary crown with using the super bond, which is adhesion bond. So this is finished with implantation. This is 3 months after. 6 months, I set the abutment and the temporary crown. This is the final set. I'm going to show you other immediate implant case. The first premolar. Also, patient came to my clinic to having pain due to root fracture. That took the CT and they know how thickness of the bone. So I extract the tooth. I press the implant. There's a space between implant and the margin of the socket. There's a much space. I use the bone graft. Also, I use the membranes with mesh. So after 2 weeks, membranes shrinked. And I remove the membranes, the nice heal. So after 3 months, after 6 months, I set the final restoration. This is before taking the first CT, and after setting of the restoration, taking CT. All the time, I'm checking the CT after I press the implant. The summary and the conclusion. Immediate implant placement. To perform flap-less surgery, the operator must have suitable experience as to be competent in procedure. It needs full knowledge and appreciation of the anatomy. It may be necessary and it's most reliable to use the CT scanning during the planning stages to certain further information before commencement of the treatment.